This conference will now be recorded.
Yeah, good morning once again. In the last class, we discussed about portal hypertension. I'll be continuing about the liver. So today we'll discuss about infectious conditions that we encounter. So infections are again broadly classified again. So they can be viral infections, they can be bacterial infections, they can be fungal infections, there can be parasitic infections. So when it is a parasitic one, we call it as infestation. While it is an bacterial and viral, we call it as an infection. So that is broadly again classified like that. So what are the common things related to liver which you come across in day-to-day life is hepatitis. So it can be caused by hepatitis A, C, or B viruses, or hepatitis E. The most common ones are hepatitis B and C, followed by hepatitis A. The common bacterial infection is pyogenic liver abscess, particularly in patients with low socioeconomic status uh, and who are taking polluted water, etc., as the diet. And in infestations, these come the parasites that are amoebic and hydatid cyst. So coming to viral hepatitis, see, it is one of the most common cause of liver disease in the world. So it can be, I'm broadly saying it as viral hepatitis. It can be due to ABC of hepatitis. So hepatitis, it is very uncommon to present it as an acute liver failure. Very rare cases, the patient can have acute hepatitis. Most commonly, it is a chronic case where over a period of 5 to 10 years, the patient develops nodules and go into cirrhosis of liver. So always viral hepatitis, most commonly, is a chronic disease. So hepatitis is a medical disease. So why it is related for a surgery student to know about viral hepatitis? So in any end stage disease, surgery is the treatment of choice. So if the patient goes into end stage liver failure, you will go for transplant. So for that, for the knowing the for doing transplant, you should know the functional status, pathophysiology, and everything about the disease. So again, patient having viral hepatitis, chronic viral hepatitis. For example, patient is having HBsAg positive. You are going for some other surgery unrelated to liver. You should always assess his functional status of the liver because you are going to induce him into anesthesia. So the metabolism of every drug, most of the drugs happen in the liver. So the functional status of the liver is very important. And chronic viral hepatitis, common cause of hepatocellular carcinoma. It first leads to cirrhosis and then it can lead to hepatocellular carcinoma. And again, another important thing is transmission from patient to surgeon is very high. So always when you are doing a case of positive patients, for example, hepatitis positive or HIV positive, or now the new normal, which is COVID positive. So the safety for the surgeon is paramount, because the surgeon operates on other patients too. So if the surgeon gets infected by operating on a positive patient, there are high chances of the surgeon transmitting the disease to other patients. So in certain diseases, for example, these viruses, we go with a WHO protocol. So we use double gloves and disposable gowns and disposable draping sheets, etc. Everything in the OT which we use will be disposed of. So viral hepatitis is one of the infection to the liver caused by virus. Just remember it like that. So the most common one are B, C, and A, followed by D, E, and G. B and C are more important. Hepatitis A and hepatitis C can cause epidemics. So the mode of transmission is fecal-oral route, and distinguishing factor between HPV and other viruses are it has a DNA genome. HPV has DNA genome, while rest of them have RNA genomes. So any viruses, determining them is based on the antibodies and antigens. The most common ones are IgG and IgM antibodies, which are present in the early infection. For suppose if the patient is infected in the initial stages of 14 days to 1 month period, you will have high levels of IgG and IgM antibodies. So IgG antibodies persist longer term, whereas IgM is only about in the acute phase of the infection. Coming to HPV infection, that is HPV hepatitis B virus. The hallmark for identification is HPSAG antigen. So this is the hallmark for diagnosis. So it appears in the serum from 1 to 10 weeks after infection and disappears after 4 to 6 months. But in chronic patients, it always gets positive, as it is always present in the serum of the patient. So today, rapid tests are being done everywhere, and the most commonly done rapid tests are hepatitis B and C, which we do commonly. So in acute hepatitis B, here you can see the HBsAg positivity in the initial stages. Over a period, it gets persistent. Coming to hepatitis A, in common, it is common in third world countries, that is underdeveloped countries. And the main mode of transmission is fecal-oral route, unlike hepatitis B and C, which is direct contact. So where low socioeconomic income groups are present, that is in slums and underdeveloped countries, where people are aggregated together in a closed space. So hepatitis A is more common there. So coming to hepatitis B, as I said, it is through contact transmission, that is sexual intercourse, heavy drug abuse, transmission from mother to child, and it is also the most commonly transmitted virus in the healthcare professionals, because as I said, they are in contact with the for example, if you take a surgeon, while you're operating, if you have a needle prick or cut on your finger due to a scalpel or some instrument, you are going to be exposed to the virus, and it is very high chance of you getting infected with hepatitis B virus. So surgeons of all the branches, surgeons and gynecologists who are operating on a patient have highest risk due to hepatitis B and hepatitis viruses and HIV viruses. These are not airborne viruses, so it should be the people who are prone in getting in contact with the patient has the highest risk. Unlike COVID, which is a airborne virus, so they are anesthetists and critical care people have highest risk compared to surgeons. Coming to hepatitis C, compared to the other viral hepatitis, this occurs in a younger age. More than 20% of the HCV infections caused by sexual transmission, and hepatitis C has the more chances of going into cirrhotic liver and ending in and landing up in hepatocellular carcinoma, hepatoma. And the risk of transmission is higher than in HPV, it is hepatitis B and HIV viruses. So hepatitis is more important for surgeons. Common thing is here needle stick injuries or prick injuries while you are changing a dressing or doing a dressing or operating on the patient. The chances of infections are high. So always the person who is attending the positive patient should always wear based on the WHO protocols. The double gloves. There are some protocols given in WHO, so those are important. So the pathogens is mostly it is cytotoxicity, this cellular toxicity, and due to the immune response, this causes fibrosis and hepatic injury. In hepatitis A patients, 80% will develop symptoms, and more commonly, hepatitis A will have an acute response compared to hepatitis B and C. The mortality is very low in hepatitis A, which is less than 1%. And coming to hepatitis B, symptomatology, about 70% of the patient with acute hepatitis B virus will have subclinicular anti-icteric hepatitis. That is, patient will not have jaundice but will have hepatic inflammation. So early diagnosis is somewhat there can be a delay in diagnosing hepatitis B. So the 70% will have anti-icteric hepatitis and the other 30 will have an icteric hepatitis. And the incubation period is about 1 to 4 months. Usually it is about 3 months. So the constitutional symptoms, like any infection, there will be high-grade fever. The patient might have diarrhea and vomitings. Those are not present in every such case, but most common, and the patient will surely have fever. And what is fulminant hepatic failure is very severe form of hepatic failure. So this develops in about less than 0.5% of the patients. But if it is developed in a patient, the chances of him dying is very high. So it will have more than 80% mortality rate. So other problems with hepatitis or any viruses, due to the immune system is going to be in an overdrive, trying to counter the injury or reaction that is caused by the viruses. So at this time, concomitant infections like bacterial infections or fungal infections also can occur in the patient because his immunity levels are getting decreased while fighting the virus. So chronic hepatitis B patient will always be in an immunocompromised state. The other extrahepatic manifestations of hepatitis B virus are polyarteritis nodosa, glomerulonephritis, which occur in the liver, and papillary acrodermatitis. These are some extradermal features which are not seen in every patient, but you should be vigilant about these manifestations, which can lead you to an early diagnosis. Uh, the sequel of chronic hepatitis B infections are sometimes it can be none. It can be just be an infestation without any uh, end result. The patient may suffer for 20 years without any progression in his disease. So that is a good one. But in most patients, it will be caused to cirrhosis, then into hepatocellular carcinoma, which in and causes hepatic failure and then death. So that is the sequel in which any virus will affect the liver. Of these three, always remember hepatitis C is more what do you call it, more rapid or more aggressive in nature compared to hepatitis B. Hepatitis C will cause cirrhosis in most patients. Going to acute HCV infection, that is hepatitis C infection, the uh, pathophysiology and everything is the same. So I'm not going into pathophysiology because you will learn that from medical. I mean, general medicine. Your general medicine faculty might teach you about hepatitis improper, about the pathophysiology and the presentation forms. I'm not going in detail into those things. Which the percentage of jaundice, that is icterus, is less than 20% in these patients. So again, as I said earlier, chronic HCV infections, about two-thirds of the patient will land up in chronicity. That is, they might land up into chronic liver failure. Again, I said it earlier that patients with chronic HCV infection are at higher risk for developing cirrhosis and HCC. So, while compared to other, the risk of developing HCC is about 4% per year, which is very uncommon in hepatitis B and hepatitis A. The other thing is hepatitis E virus. This is introduced orally. Compared to the other hepatitis E virus will develop jaundice, that is icterus in 50% of the patients, but it does not cause lasting effects. As there is vaccine now to HCV vaccine is developed. HPSAG vaccine, hepatitis B vaccine is present in your what do you call that vaccination schedule, Indian Association of Pediatrics vaccination schedule. Hepatitis B is included, whereas hepatitis C, the vaccine is still not in an advanced stage of production. So there are high chances of failure in hepatitis C vaccinations which have been produced so far. And, and hepatitis B vaccination, those who are not vaccinated at birth should get vaccinated uh, if they are in a high risk group, that is healthcare professionals. So that is one point you should remember. Currently, all children 11 or 12 years old should be vaccinated because this is not uh, that big a problem which we are coming across, because most of the children born in from 2000s. From 2000s, everyone is getting hepatitis vaccination. In the according to the IAP immunization schedule. Those who are born earlier to that, it is not included in the immunization schedule. So the people used to get vaccinated outside. So coming to treatment, it is always the supportive treatment, because there is no treatment as such for any virus. Any virus, you can't treat anything. You can just reduce the load. You can just support the patient for gaining his immunity, while the body counters it. So the approved therapies are interferon alpha, and lamivudine, which is a nucleoside analog. So that is in brief about viral hepatitis. And other thing that you should remember is, if the patient goes into cirrhosis and end-stage liver failure, the only treatment of choice that is available is the patient can get transplantation. Liver transplant can be done. Coming to pyogenic abscess, it is mostly occurs in the right side of the liver. Pyogenic abscess is very important, and from a surgical point of view, this is more commonly encountered than you deal with hepatitis, because you don't do anything related to hepatitis from a surgeon point of view, except for transplantation or something like that. But coming to pyogenic abscess, the draining and everything is done by the surgeon. So this is important for us. So coming to the how it is caused, it can be local spread or hematogenous or ascending suppurative cholangitis. So if there is a infection in the portal system or in the biliary tract, that can ascend into the liver, get lodged in some part of the liver, forms a nidus, which is the starting point of a inflammation. From that nidus, it can cause an abscess. In the left lobe of the liver, it is less common compared to the right, but when it is in the left, you have a technical difficulties. If there is a left lobe abscess, they are in close proximity to the major vessels of the liver. So this causes a technical difficulties while you are trying to treat the patient. In the caudate row, it is very rarely involved. And coming to the percentages, about 50% of the hepatic abscesses are solitary. The size varies from small sub-centimeter abscesses to very large abscesses. That can be more than 9 centimeters, 10 centimeters. We have seen abscesses that are more than 10 centimeters also. So size varies. And they can be multiloculated or a single cavity. What is multiloculated is, within a single abscess, there may be multiple cavities within a single large cyst. That is multiloculated. So whenever you are doing an abscess, be it in the liver or any other abscess present all over the body, always you should break the locules, because if you open and drain a abscess, you will get the pus out, but you don't know how much of the pus is still remaining, because if it is loculated, you should break the other things and evacuate the rest of the pus from the cavity of the abscess. So always locule should be break in an abscess, be it in anywhere in the body. And most commonly, it is caused by the anaerobic organisms like Escherichia coli, Klebsiella pneumoniae, Streptococcus aureus, and Enterococcus, and Bacteroides and Streptococcus viridans. More common are E. coli and Klebsiella pneumoniae, and staph and staphylococcus. Klebsiella, it is usually a gas forming abscess. So the presenting features are any abscess or infection will cause. You should always write it with a closed eyes. You can just say fever, weight loss, malaise, that is generalized body pains, and chills and tigers are common for any infection, be it in the leg, be it in the face, be it in the body, anywhere. Any infection will cause these generalized symptoms. So if anyone asks what are the symptoms when asking about an infection, just blindly say fever, weight loss, body pains, and chills and rigors. Coming to the signs, based on the situation, based on the site it is present. The liver is present in the right upper quadrant. So there will be a right upper quadrant tenderness. In some cases or in chronic case, that is, the patient didn't come for hospital or he didn't take medical advice, he can land up in jaundice and hepatomegaly or a long duration. So this can lead to sepsis. And the other laboratory investigations are CBC, that is complete blood count. So you'll get a WBC done, and you can see for leukocytosis, anemia if present, or elevated LFTs. Because jaundice, if there is jaundice, should always suspect an elevated enzymes, liver. The imaging, chest X-ray will give you right-sided pleural effusions or collapsed lung in the right lung, because it is directly present above the it is present directly above the liver. So right-sided pleural effusion is common finding in these patients. In ultrasonography, you find the abscess of the present in the liver, whether it is in a liquefied state or in a solid state, whether it has multilocularity or a single cavity. These are all things you can distinguish in the ultrasonography. Then CT and MRI, these are more enhanced imaging. So always better. They are always better than ultrasound. Coming to the treatment, conservative one is the antibiotics, which is metronidazole 850 mg TID. In your books, it will be given as 400 mg TID or 800 mg TID, but the ideal dose is 850 mg dose TID or QID. TID is thrice daily. So that is about every 8th hourly. But QID is 6th hourly. So the other things are after a dose of antibiotic treatment, the patient is responding, the abscess gets liquefied. It turns into a clear pus inside the abscess cavity. Then you go for percutaneous drainage. You place a drainage tube into the cavity of the abscess and you drain it out. Through this percutaneous drainage is done with the assistance of radiography, that is under ultrasound guidance, because you should know where you are puncturing in the liver. If you somehow damage some artery or vein or biliary tract in the process, you will end up in soup. So percutaneous drainage is always done in under ultrasound guidance. Then comes the laparoscopic drainage, where you drain it through laparoscopy. These laparoscopy and surgical are operative procedures, whereas percutaneous drainage is minimally invasive techniques. In some rare cases, there might be a need for liver resection, because long-standing abscess, there might be hepatocellular damage, so which can't be reverted back. So at that stage, you go for liver resections, but those are very rare. So that is about pyogenic abscess, and there is something called as amoebic liver abscess caused by entamoeba histolytica. So this is generally called as amoebiasis. And again, most amoebic abscesses occur in the right lobe. This is due to this. You should always remember the second point. If you remember that why it is happening, you'll never forget it. So the right-sided preponderance is because the right lobe receives majority of the blood from the superior mesenteric vein. So the superior mesenteric vein and splenic vein causes combines to form the portal vein, which I have said in the last class. So this portal vein has majority supply to the right lobe. So as amoebiasis infestation is more common in the large intestine, that is cecum and ascending colon, which is supplied by the superior mesenteric vein. So this flows into the portal vein and into the right lobe of the liver. So that is the reason why, be it amoebic or be it pyogenic abscess, gets more common in the right lobe of the liver. So here, the distinguishing feature is when you do a percutaneous drainage, you'll say anchovies or pus. So the color of the fluid that is drained will be in anchovy. If you want to know what is anchovy, just type it in your Google and see how the color will be. So here the picture won't be that descriptive here, so you can't make it out. This is anchovies or pus. So coming to the life cycle, there are 3 stages, that is prophyzoid stage, pre-cystic stage and cystic stage. I'm not going into the life cycle part because you will study it in your pathology. So your second year, right? So you should be knowing this by this time. So this is a cross life cycle, bypassing all this. So coming to the risk factors, so the major risk factor is immunosuppression and travel to a tropical region. So for example, India is a tropical region, but if the traveler who is coming from a region which has high hygiene standards, but in India the hygiene standards are low compared to the Western countries. So water is the most commonly polluted thing in here. So that is the most common route through which someone gets a amoebic liver abscess. So other things are immunosuppression, malnutrition. These all these things are confounding factors. Cancer. Why cancer? Because the cancer patient will always have an again immunosuppressed state. Old age, pregnancy, all these things are the cofactors. But the major ones are always uh, lack of personal hygiene or lack of undercooked food or improper hygiene, etc. So the most common presentation features are abdominal pain and fever, as it is again an infection. Parasites we call as an infestation, but that infestation causes infection. So fever is also always present, and generalized body pains are present. Colds, chills and rigors are present, and occasionally jaundice, because there is hepatocellular damage. So always remember, liver and biliary tract. You have referred pain to the right shoulder. This is one thing you should always ask the patient if you are suspecting liver related illnesses. You can always ask if there is a pain that is referring to the right shoulder. So if the patient is having cough, when you have diagnosed an amoebic liver abscess, you should always suspect it is a complicated abscess, because what happens is here the liver abscess which is present gets ruptured into the pericardial sac through the diaphragm and pleural cavity. So this causes the patient to land up with pulmonary symptoms. So that is a complicated amoebic abscess. So the major diagnosis is always LFTs, through which you can suspect the enzyme irregularities present there. So always ALP will be increased, and the most common LFT abnormality is prothrombin time. So any hepatocellular injury, be it in hepatitis or injury or cirrhosis or hepatic failure, what happens is the prothrombin time gets increased. And the other important laboratory evaluation is circulating anti-amoebic antibodies. So these will be present about 90 to 95% of the patients. So here you can see this is the right dome of the diaphragm. So it gets elevated, and there is pleural effusion in the right side. So this is the right lung, and there is effusion where you can't see the prostophrenic angles. In ultrasound, you can see this is the liver pipe thing, and this is the abscess which is there. So in the CT scan, you can clearly make out. So this entire thing is the liver, and this is the abscess. It has a mild loculation here. So this is a loculation. So if you puncture it and drain out, only this part of the abscess gets drained out, whereas the rest abscess stays intact and can cause again the same process of disease in the future. So always make sure that you should break the locule present in the abscesses. So when comparing it is, pyogenic abscess is more common in more than 50 years or older age group, whereas amoebic abscess is more common in less than 50 age group. Amoebic abscess compared to pyogenic abscess is more solitary, and both of them will have abscess most commonly in the right liver. So pyogenic abscess, you need not ask the history about an endemic area travel, but in amoebic abscess, you should always ask it, and it is very important. So in an amoebic abscess, if you ask the patient for a blood culture, there will be negative because there is no bacteria present in the amoebic person. So whereas in pyogenic abscess, you will have positive blood cultures. And elevated ALP, which I have said earlier, ALP rise is common in both the abscesses. Any hepatic injury will cause rise in the ALP levels. The prothrombin time will be increased in both of them as well. So the treatment is again the same. like the pyogenic abscess. We go for more commonly these days, percutaneous drainage is the best modality of treatment. In end stages or in late, if the patient present to you in a late stage, you go for surgical treatment. So treatment is again metronidazole 850 mg, not 750 mg for 14 days. Don't write it down. These slides are not correct. So metronidazole, always remember 850 mg TID for 14 days. In some, you can mix and match with the other available drugs. With the idoquinol, you can metronidazole 850 mg plus idoquinol 650 mg TID for 21 days is also given. But more commonly and most effective treatment is always metronidazole 850 mg. So coming to indications of percutaneous drainage, it is if you go for an radiological evaluation, you see the size of the abscess. Based on the size, you can assess whether it is going to rupture or not. If it is in impending rupture state, you go and just drain the abscess percutaneously. So when again another important indication is when the abscess is large. If the abscess is more than 4 centimeters, you should always try to intervene and drain the abscess because it raises the chances of rupture. If an abscess gets ruptured, so entire peritoneal cavity gets infected, and this will cause increased in mortality rates. It is better to drain before it ruptures. If the abscess gets ruptured, yeah, then the patient will collapse very rapidly. And you should go for surgical management, which is open laparotomy. You should do laparotomy and open the abdomen. So here you can see this is the cavity present. This is one cavity. So this is the bridge that is separating both these two locules. So you should always break these two things. So into this thing, they are passing a needle. Needle is passed into the abscess cavity and aspiration is done. So in surgical drainage is always laparotomy, or you can try if in percutaneous drainage, uh, if there is no availability for a guided aspiration, you can go for laparoscopic drainage. So this I have said earlier. So before it ruptures, any be it amoebic abscess or pyogenic abscess, the mortality rates are very low. But when the abscess ruptures from 5%, it will go as high as 50% mortality. So that's it for today. In the next class, I will finish the infections part with the hydrated disease, and I'll try to include a resection of the hydrated cyst excision of liver. Hydrated disease is very, 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 very rare these days. We have improved our hygiene levels in India. So if I haven't seen an hydrated disease case in my entire post graduation and my years of practice. So that rare these days. But the old surgeons, our professors, have seen these cases at a daily basis. So that's a good thing. So, and hydrated disease is very important for you, both in your second year and your final year. In second year, it is an essay for you from parasitology. So I'll stop here.